Steve Paz, ¿alguna pregunta? Ahora Juan, que quería consultar algo.
Sí, bueno, en relación al tema de WALANT, sí, llevo algún tiempo haciéndolo y quería recalcar también el tema de alguna, si tiene alguna complicación con el tema a nivel sistémico. Yo, por ejemplo, concretamente tuve un paciente que por suerte estuve en quirófano, estuve cerca de un anestesiólogo porque es una taquicardia bastante incontrolable. Suponemos que nos pasamos de dosis y tal. Y lo tuve yo como que revertir esto. O sea, que no es una cosa que también tener la alegría de ir poniendo y haciéndolo tranquilamente, porque te puedes dar un susto. Yo pienso que hay que tener en cuenta esto. Otra cosa que yo lo que encuentro que hay cantidad de ventaja a nivel económico, esto es seguro. A nivel económico y a nivel de función igual. No es lo mismo que hagas una tenografía y lo compruebes, como decía la doctora, ese momento de flexión, extensión, lo que hagas. Pero con manos así muy traumáticas, yo sigo, la verdad, prefiriendo a veces hacer el bloqueo que te hace el anestesiólogo, el torniquete para ver bien las estructuras, que no desangre, no tiene nada que ver un sangrado profuso durante la cirugía, que tampoco eso al menos los pueden controlar con igual. Entonces hay unas ciertas cosas más que nada se había tenido este tema de alguna complicación, algún susto, que nosotros sí que lo hemos tenido.
Sí, digamos, cuando yo he ido haciendo mucho, este efecto está escrito, ¿verdad? Uno va infiltrando debajo, siempre que uno avanza hay que aspirar porque uno sabe que la punta de la aguja esté en un vaso y demás. Pero a ver, está escrito, hay que prevenir al paciente de esta posible sensación de calor, de taquicardia y demás. Es una cosa que es parte de lo que hay que explicar con el paciente. Pienso que con respecto, digamos, a lo de la mano traumática, hay que ir progresando, ¿verdad? Cuando llega una mano así, tal vez no es el primer paciente, ¿verdad? Porque tenemos que ir adquiriendo esa confianza, hay que tener claro cuáles son las dosis, digamos, tóxicas de la lidocaína y demás que podemos utilizar las diluciones, etc. Pero sí, concuerdo que no es una cosa que me aventuro a la primera porque fue lo que leí, ahora voy a hacerlo, ¿no? Hay que ir despacito haciendo la curva, como debe ser posible. En los países de nosotros muchas veces pasa que uno le dicen, o la recomendación es, mire, vaya al cadáver, vaya a esto, vaya a lo otro, primero un caso sencillo, luego más complejo, y sabemos que los pacientes en los países de nosotros no vienen así, ¿verdad? Que muchas veces el paciente primero que llega es el complejo. Entonces,
si nosotros hemos hecho incluso la transferencia del tríceps de tríceps a bíceps con WALANT, es
sí.
Lo máximo que hemos llegado, digamos, y muy bien, o sea, todo.
Sí, ya eso se ha ido extendiendo, incluso, digamos, los cirujanos de pie están haciendo cirugía con WALANT y demás. Bueno, creo que ya tenemos al doctor Lalonde, así es que welcome, Dr. Lalonde.
Thank you. I don't think you've played my video yet. It's very nice to be here with you today. Are you going to play the video? I hope so.
Yes.
And then I'd like to make some comments and answer questions after you play the video.
Okay, thank you.
Hello there. Thank you for giving me the honor of speaking to my friends in Ecuador about how to do a lot of cases efficiently in a public system quickly with WALANT. This is how we've been doing things like an axe injury with broken bones and cut tendon to the hand for many years in Canada. We inject the local anesthesia, K-wire the broken bones with field sterility in a minor procedure room, and go ahead and repair the tendons. This is how we do them all, and we've been doing this for at least 30 years, and here is the patient at 3 years after injury. You don't need to do these cases in the main operating room. In fact, we the infection rate is exactly the same whether you do it in the main operating room or you put K-wires in a minor procedure room. In a series of over 1,000 cases in 12 Canadian cities. In Ecuador, you could and should do your spaghetti wrists in minor procedure rooms with WALANT like we do in Canada. There's no reason why you can't. And is the infection rate higher for doing flexor tendon repairs outside the main operating room? No, the infection rate is not higher doing flexor tendon repairs with good field sterility as shown by this series from London and another series in Canada. So in Canada and the United States, we're doing all these trauma procedures Monday to Friday, 9 to 5 in minor procedure rooms with field sterility. And we're showing that our infection rate is no higher than in the main operating room. And you could do the same thing in Ecuador. There are many publications just like these, and this whole science is the science of evidence-based sterility, which is the rate of infections with differing levels of sterility. You could show these to your administrators so they could change their minds. Your administrators will be pleased to read the more than 50 papers showing how much cheaper it is to do procedures in a minor procedure room with much less waste. All of this unnecessary sterility from the main operating room is costing you a fortune in Ecuador, and it does not decrease your infection rate. So it's a total waste of money that you could be spending somewhere else in your healthcare system. And you would be contributing less garbage to the environment. But to do this, you need to change the way you think about surgery. With general anesthesia, you only do one case at a time, right? And then you waste 30 to 45 minutes between each case, waiting for the nurses and the anesthesiologists and for somebody to wash the floor that they don't need to do. The mindset of WALANT is different. You inject the first 3 patients while the nurse brings the first patient into the room. So you inject them outside the operating room on a stretcher. By the time you're finished injecting the third one, the first one is ready to operate. So you go in the procedure room, operate on the first one, and then you leave the procedure room and inject the fourth one while the nurse changes the room and brings in the second patient. You do not waste any time at all between cases. So you can process your trauma patients one after another, after another, after another. You can do a whole bunch of K-wires and flexor tendons and everything else you need to do quickly. These could all be your K-wire patients, your flexor tendon patients. They've all been injected with local anesthesia and they're waiting outside the minor procedure room for you to do the surgery. They need to wait because you need to have at least 30 minutes for good epinephrine vasoconstriction and good lidocaine effect. They can wait, but you don't need to wait. You can be operating on other patients while their local anesthesia is working. But you have to get out of the just one case at a time mindset. And you have to inject at least 2 patients before you operate on the first one. This plate removal was done last week by Dr. Moise from Burundi with WALANT. He took this plate off of the fibula. You could do this case in a minor procedure room with field sterility in Ecuador. You might need full sterility to put in the plate, but to remove the plate? No. Prepare 200 mils of 4% lidocaine with 1 in 400,000 epinephrine and inject visible and palpable local anesthesia 2 centimeters beyond anywhere you're going to dissect, including both sides of the fibula. And wait at least 30 minutes before you cut. You can operate on other patients while this patient is numbing up. The surgeons in Ghana started this minor procedure room in Kumasi in 2017. Now they work in there 7 days a week doing trauma. They have nurses in there so they can do trauma cases on Saturday and Sunday. And they've put a new procedure room in Accra, Ghana, because this one has been so successful.
WALANT is a game changer in access to surgery and to help alleviate poverty in East Africa. Surgery is essential to help people get back to work, to alleviate poverty, but traditional surgery is too expensive and unaffordable. WALANT alleviates poverty because it does not require general anesthesia or the main operating room. Wide awake local anesthesia, no tourniquet surgery, is a disruptive and game-changing innovation that alleviates poverty in low-income countries. We have initiated WALANT procedures in more than 30 hospitals in Kenya and more than 50 other hospitals in the neighboring countries. Thank you.
It's very important to remember that you need to do two things to not hurt people when you do WALANT surgery. The first is put in a lot of volume, blow it up. Stay underneath 7 milligrams per kilogram, but as long as you stay underneath 7 milligrams per kilogram and you inject tumescent local anesthesia everywhere you're going to cut, and you wait at least 30 minutes before you cut and go do other useful things while you're waiting, then you're not going to hurt people. And you only need 3 things to do hand trauma outside of the operating room. Any room with no special ventilation. You do not need special ventilation for minor procedure rooms. If you're putting in a total hip, yes, but for everything else, no. You need something to insert K-wires, and you need an X-ray machine to make sure your K-wires are in the right place. If you want to do 15 trauma cases a day in your minor procedure room, you need 15 basic trays just like these. You know, to do surgery, you really only need 5 basic instruments: scissors, forceps, etc. All of the extra instruments like towel clips and send retractors, they can be wrapped separately. And you don't need an expensive ceiling light. For years, I operated with nothing but a headlight, and it's actually a lot better than operating with a ceiling light. Even in the main operating room, I quit using the ceiling light. Your hospital will be very happy to give you a WALANT room when you show them the evidence that the infection rate is the same and that it costs a lot less for everyone, the hospital, the insurance companies, and the patient. To get hospital administrators and nurses on your side, you must always make it about the patient. It's easier, safer, cheaper, better for the patient, always about the patient. And never try to go to a committee and ask for a change. First, you must make a 10-minute appointment to see each committee member one at a time and ask them for their opinion on an idea. Give them a well-prepared 5-minute pitch with slides on your laptop and ask them what they think. Everybody loves to give their opinion. They will love to give you their opinion. Let them talk and just listen. Thank them for their important ideas and leave. After you've seen all the key decision makers, some of them twice, then you're ready to take it to the committee after you know that everybody's on your side. If you're still doing your K-wires and other minor trauma in the main operating room, please stop. To move your surgery to a minor procedure room costs you nothing. All you have to change is your mind. Thank you so much and have a great meeting.
Thank you. And thank you, Cristian Castro, Daniela Hernandez, and Maria Ganim for great talks. I'm going to be in Guatemala on March the 18th for a whole day of lectures, if any of you want to come up there. On March 18th, and then March 19th and 20th, we're doing WALANT live surgery. So you're welcome to apply and join. And I'm open to any questions, but I just want to make one more comment. People who are afraid of WALANT, usually there's two reasons. One, they've never done it. So it's always they're afraid of, well, what if, yes, but these what if things are usually just not a problem, or we wouldn't be doing it all over the world. And the second reason that people are afraid of starting WALANT is because it's work. You know, we have to make an effort to change. And it's difficult for surgeons to change. But look, I'm old, and I managed to change. I think that you can also manage to change. It's a little effort, but it's better for the patients. So think about it.
¿Hay alguna pregunta del auditorio para el doctor Donald? We have questions, doctor?
Yes.
Yo veo que aquí en nuestro medio, en la ciudad de Cuenca que trabajo, tenemos una presentación de la lidocaína al 2% de epinefrina. Uno, cuando va a hacer el WALANT, la primera pregunta es ¿cómo diluyo esta sustancia? ¿Cuánto pongo de este tipo de epinefrina? ¿Y cuánto pongo de suero? Hay muchos cuadros, yo sé que en la literatura hay muchas descripciones, pero a veces es muy confuso esto, no está muy claro.
Yes.
Yeah.
You're
Do you get it?
You're asking how to dilute 2% lidocaine because you're seeing many different ways of doing it in the literature and it's confusing. Is that right?
Yes, we trying to get how to use the conventional lidocaine that is 2% already prepared.
Right. So what you do is you take 25 milliliters of 2% lidocaine. That's the maximum. So 25 milliliters of 2% lidocaine. You add that to 25 milliliters of saline. So now you have 50 milliliters of 1% lidocaine. To that, you take pure epinephrine, 1 in 1,000, the little brown bottles, and you take an insulin syringe and you take 0.5 milliliters of epinephrine. So 0.5 milliliters of epinephrine in 50 milliliters of 1% lidocaine. That gives you 50 milliliters of 1% lidocaine with 1 in 100,000 epinephrine. Never go higher than that, and you will never be toxic, I promise. Because the plastic surgery literature shows that we can use 35 milligrams per kilogram. So 7 milligrams per kilogram is extremely safe, and you will not see toxicity with 7 milligrams per kilogram. So when you need more volume, like if you're taking off a plate from the radius, or if you're doing a radius fracture, then you simply add saline. So you take 50 milliliters of 1% lidocaine with 1 in 100,000 epinephrine, and you add 150 milliliters of saline. Now you have 200 milliliters of 0.25% lidocaine with 1 in 400,000 epinephrine, which is going to work very well if you give it 30 minutes to work, and you will have 3 hours to operate with very dilute local anesthesia. The key is big volume so you can see it everywhere before you cut, and wait at least 30 minutes before you cut. All of this is in the Wide Awake Hand Surgery book. And most of the papers that talk about this say the same thing that I'm telling you. Thank you for the question.
Yes. Algo que nosotros hemos hecho acá para sentir que hacerles sentir a los anestesiólogos parte de la cirugía es que lo preparen ellos. Así ellos pueden hacer sus cálculos y sumas y restas y nos las preparan previamente, entonces son parte de la cirugía o se sienten parte de la cirugía de alguna manera. Y si no tenemos anestesiólogo, básicamente hacemos lo que el doctor Lalo ha mencionado. So, Dr. Donald, we don't have any questions more. So, thank you for being with us. We appreciate you a lot. You are part of the Kumano. You are an honor member, so welcome every time you visit.
It's my great honor to know all my friends in Ecuador. Thank you so much for inviting me. Have a great meeting.
Thank you.
Adios.